Good morning, everyone. We'll get started in just a moment. Give folks a chance to join. Good morning. Glad to see the chat's working.
Such a friendly group compared to my normal Zoom calls.
Very, very interactive. It's nice.
Seeing so many of our Voices of Hope coaches in the chat. Love it. Glad y'all are here. And Jimmy Chadwell, our president. Hi, Jimmy. Glad you're here. All right, we can go ahead and get started. So, welcome to the Kentucky Harm Reduction and Recovery Community of Practice webinar series presented by Voices of Hope and the University of Kentucky Harm Reduction Hub. My name is Brooke West. I am a person in recovery and the training and education manager at Voices of Hope in Lexington, Kentucky. The goal of a community of practice is to bring together a group to engage in training, share best practices, and network around a common interest. Today, the topic of our community of practice is recovery support models for adolescents to build recovery capital, presented by Dr. Emily Hennessy, Associate Director and Director of Biostatistics at the Recovery Research Institute, Associate Director of the National Center on Youth Prevention, Treatment, and Recovery, and Assistant Professor of Psychiatry at Harvard Medical School. We are so grateful you are sharing your expertise with us today. We will also be hearing an update from the University of Kentucky Harm Reduction Hub, but first, a couple of housekeeping notes. If you are a peer support specialist interested in continuing education for this webinar, you'll need to complete the survey that we will place in the chat toward the end of the session. And we have the chat feature on, which most of you have discovered, so you can participate during the webinar and ask questions. And stay tuned for a webinar announcement that we'll share at the end of today's presentation. So today's update from the Harm Reduction Hub will be presented as a conversation led by Dr. Amanda Fallon Bennett, who is a woman with many titles, including my personal co-conspirator and friend. But for today's purposes, she is a co-founder of Voices of Hope and one of the co-leads of the UK Harm Reduction Hub. And I will turn it over to you, Amanda.
Thank you, Brooke, for that introduction. And so for those of you who have been joining monthly, we will be giving the Harm Reduction Hub update a little bit differently. And so what we wanted to do today was to have more of a conversation. And so we will present, I'm going to present a little bit, of our data. And so for those of you who've been used to our previous formats, if you're very interested in getting the data, don't worry. It's all the data that we normally present is still coming out in our newsletter later on this week. But today, I'm so excited to facilitate a conversation with several experts who are here to speak about harm reduction efforts in the drug supply in Perry County. And so those joining me also have many titles, and so I will let them introduce themselves when we get to the panel and speak to you a little bit about their work. As always, we're very grateful for the support of Vital Strategies for the Harm Reduction Hub. And just in case there's anyone joining new, the Harm Reduction Hub is a multidisciplinary initiative where we are able to work with partner sites, we currently have 10, to analyze residue in used syringes. So it's really a trash to treasure model. We can come pick up your used syringes, test them, and report back information that can inform clinical practice, harm reduction education, and research studies. And so to date, we've tested over 4,000 syringes. And here's a picture of Naomi, one of our team members, a very dedicated going out and picking up syringes in our snowstorm. So, but part of the reason that we're going to do this today more as a conversation is because we want to learn from you. So last month, we heard a lot in the chat about different things that you've been hearing about the drug supply. So for today, what have you been hearing about the drug supply lately? Hearing anything about increases in overdose, strange color, taste, anything like that, please put it in the chat. We take that back to our team, and it's really important to us. So this is the only data slide that I'm going to share with you all today. And These are our January 2026 testing results. And these are the top 10 I lied. There's one more data slide coming up, but these are the top 10 substances that we found across all counties in January. And so I just would like to point out, for the purpose of this discussion, because we're going to have a discussion on is fentanyl really in everything, that we found fentanyl in 32% of all of the syringes that we tested in January. And we found that really, and this has been consistent all the way back since we started testing in Perry counties in September of 2025, that we find a lower percentage of fentanyl in the syringes that we've been testing from Perry County compared to Fayette and Jefferson. And so I'm going to stop my screen share now so that we can see our experts, and we're going to have a discussion. So I also want to ask you all in the chat, you can also comment while they're introducing themselves. Have you all ever heard someone say fentanyl is in everything? And what do you think about that? Where do you think that comes from? It's very well meaning. Typically, I know I've said it myself, and so I'm excited to dig into this a little bit more. And so you all have met Casey, and so I'd like to ask Dr. Young and Lena to please introduce yourself and tell us about your work in Perry County.
Sure. Lana, I guess I'll go first for us. Yeah, thank you so much for having me. I have to say that the numbers on the call, they're a little intimidating, but we'll do our best. I'm a professor in the Department of Epidemiology in the College of Public Health, and I've had the privilege of working in Eastern Kentucky now for about 15 years, mainly in Rowan and Perry County. And we've had just some amazing staff, amazing community partners who've helped us learn more about substance use there and needs for harm reduction. And Lana is one of those experts, so I'm really happy to have her on the call with me today. But I'll stop there and turn it over to Lana to introduce herself.
I'm Lana Rose. I've had the privilege of working with Dr. Young for about 7 years now. We went through Care to Hope, and now we're in the kiosk program, which is very exciting with the harm reduction. For those of you who are not familiar with it, we can get into a little bit of it, I guess, later, but that's pretty much all about me at this point.
And Lana, I think you have a really unique background. Do you want to say a little bit about where you came from before you came to work in harm reduction with me?
Well, I was explaining to Amanda earlier, I have since 1986, when I first went into working in substance use, I worked as a prevention specialist setting up Don't Say No clubs in the grade school. If you all remember, I don't know how many of y'all remember that, but that was the big push at that time for adolescents to keep them off drugs. And since then, I have worked in various positions. The longest I worked was 20 years with probation and parole, where I began. When I began, it was 90% of our people were, of course, obviously with substance use, but it was we started out. When I started, they had a lock it up facility. State of mind that we're just going to lock them all up and that'll do it. And the last project that I worked on before retiring from there was drug court and getting our drug court set up. So I kind of ran the gamut on that too. And then I ended up in working with harm reduction, which has just been a wonderful program so far. I've seen a lot better results with harm reduction than I have, and obviously Don't Say No and other programs that other philosophies that this country has held, up until this point. So been very excited with it.
Thank you all for coming in and joining us. And so Callie has shared in the chat that she has heard in Fayette County that fentanyl's in everything, but people in Bourbon County very much disagree. So I think that sets us up pretty perfectly to have a discussion about regional differences, as well as, where this comes from. And so I'd like to start by asking the panel, where do you think people, we do hear people say fentanyl's in everything. Where do you think the source of disconnect might be coming from?
And Amanda, do you want Casey to talk also, or do you want mainly me and Lana to respond? Or do you want the group to respond? I just want to make sure that I don't.
We're you all can share specifically about Perry County, but we have some questions for Casey as well.
Okay, good. Casey, I'm sorry, I didn't want to get in your way. Yeah, so as Amanda showed in those graphics, it's been really interesting and surprising to me to see that fentanyl is so rarely showing up in the residue checking in Perry County. It really stands out as very different from the other places, some of the other places. But I mean, you can see overall, I think fentanyl is not as prevalent as maybe we thought it might be in any of the syringes from any of the sites. But in Perry County is very rare actually. And yet, there are a lot of overdoses. So to answer your question, where is that mindset coming from that fentanyl's in everything? Because Lana and I have both heard it. I think maybe partly from public health messaging, where you see a lot of billboards and signs that, this much fentanyl can kill you, and fentanyl's in everything, and it's in your cocaine, it's in your meth. There is no heroin anymore, it's all fentanyl. And so those messages are really prevalent in like health education campaigns, it seems to me. Lana, I don't know if you have other thoughts about where that mindset has come from.
No, I agree with you. I will point out that about maybe 3 to 4 years ago, we started having a lot of overdoses from fentanyl, not just here, but across the state. And the awareness of fentanyl, we now have a down, the numbers are down on overdose, and we hear that, well, that's because of the fentanyl awareness, but I also believe it's because of the availability of Narcan. But I think when we started having the overdoses, Narcan wasn't as available. So the fear of fentanyl and that kind of spread it. And like I said, we don't see as many now as we did then. And but I don't know if that's necessarily because we have less fentanyl, or if it's just because with the Narcan coming in, we don't see it. But obviously, we have less fentanyl here. But I think it's when we started having those overdoses is when it became more prevalent that fentanyl was in everything. I think that's when we started hearing it more.
Right. And it definitely, we're seeing in the chat, it comes from the news, it comes from public health, it comes from really well-meaning places where people are wanting people to be safe and take precautions. And so I see Dave has said in the chat, there's also a difference between saying they are putting fentanyl in everything, like a deliberate spiking, versus fentanyl is commonly showing up in drugs, not sold as fentanyl. So that's a really interesting point too. And so this is a really nuanced conversation that we're trying to have in a short period of time. So we could certainly unpack this for at length, but I do want to ask, so Dr. Young, what are some of the harms of saying that fentanyl isn't everything?
I'm interested to see people's thoughts in the chat as well, but for me, I think that I've heard that the use of fentanyl test strips is irrelevant now, because fentanyl's in everything. So why distribute them? Why test your drugs? And if it's not the case that fentanyl's in everything, then maybe that's a potential harm, and that people could be testing their drugs for fentanyl, but they're not because they see it as irrelevant. I think that there's also a certain sense of like inevitability of overdose. And I think that might be self-defeating. I think we want people to feel empowered. And so to feel like fentanyl's in everything and I'm probably going to overdose because fentanyl's in everything could be harmful. Lana, I don't know if you have any other thoughts on just the harms created by that. In Perry County, at least, misperception, it seems, based on the data.
No, I agree. The biggest harm I see is to not testing because they feel like it's inevitable, that it's going to be there. And unfortunately, we've, by not testing, they may use something. They might think they're used to fentanyl when they're not actually. They've not ever had fentanyl. So.
Yeah, that's a great point. And so we have Joe in the chat is saying that if we say it's in everything, it could create a false mass hysteria. So again, it's a really nuanced point because we aren't here to say that you shouldn't take precautions, because of course, we hope that everybody will. But this transitions into a point you were going to make, Casey. Like, what do you think are some of the other harms of saying fentanyl's in everything when it doesn't connect to the data?
Yeah, I think that saying fentanyl is in everything has the potential to harm people who use drugs in other ways, like we've seen in North Carolina with death by distribution laws, blaming people who use drugs for the fentanyl crisis and the overdose crisis. I also think it keeps the focus on fentanyl as like the driver. It could keep the focus on fentanyl as like the driver of the overdose crisis and detract from conversations we could be having about how criminalization and lack of access to healthcare and social isolation are also major factors in the overdose crisis. I also think, some of what we're seeing with medetomidine and xylazine and other additives and adulterants coming up could be connected to increased criminalization of fentanyl, just the way we saw an increase in heroin's prevalence when there was a crackdown on prescribing prescription opioids, and then we saw an increase in fentanyl, or we saw fentanyl being introduced into the drug supply when there was a further crackdown on heroin. And so I think it just increases harms of unknown additives and also increases potential for criminalization for people who are already criminalized and marginalized.
Yes, and I see Van's point in the chat that the illicit drug supply is constantly changing. It always has. That's definitely right. That's why the Harm Reduction Hub exists. We are hoping that we will be able to sort of get out ahead and share information with you all about emerging substances so that people can take precautions to keep themselves safe. And Kevin is saying, yes, it could mask new threats. If we're hyper-focused on fentanyl, then we may not notice the other emerging adulterants, which that's certainly true as well. And I wish that we could talk about this, for much longer than we have, but I love seeing all the interest in the chat. I saw someone ask for the slides. We will make sure that they're up on the website. And please sign up for our newsletter where you can get many more details. I would like to sort of wrap up this conversation by going back to Dr. Young to ask, what do you think could be the impact of spreading this word about the fentanyl findings in Kentucky? I feel like perhaps there could be some unintended negative consequences if we aren't careful to make it sound like we're saying that fentanyl is not in anything. But so how do you think we should go about spreading the word about this fentanyl finding, and how might agencies change their response?
Yeah, it is difficult, right? Because we do want people to take precautions. But I think above everything else, people deserve to know the truth. And if the truth is that fentanyl is not prevalent in this case in Perry County, it's really, if you could say this, pretty solid pure meth that people are using, and they've seen a huge reduction in overdose. Actually, the county led the state in terms of the amount of a reduction in overdose. And so I think people deserve to know the truth. I think we have to be very careful with the interpretation of the data, because just because we're not seeing it in the syringe residues doesn't mean it's not there. Maybe the places collecting syringes are underserving people who are using fentanyl, and therefore it's not showing up in the syringes. So I think we have to be honest about limitations in the data, but people deserve to know the truth. And I think that they are wise enough to interpret limitations. We don't have to, it's sort of paternalistic, right? To couch it in any other way. Now, people are pretty savvy. At least that's my experience.
So I said this is my last question, but we have one in the chat specifically for you, Dr. Young, that I think you could answer pretty quickly, and it's a very interesting question. So what are the people that you work with, or your CAB members, like out in Eastern Kentucky, what are they saying about this change in the substance, in the supply?
Yeah, Dave, thank you for asking that. Vital Strategies has been a major partner for us in supporting an advisory board of people with lived experience in Eastern Kentucky. So shout out to Vital for that. I'm actually going to kick this to Lana, because she talks with people who are using every day in Perry County, including our CAB members. So Lana, will you just say a little bit in response to Amanda's question about what people there are saying?
Well, I don't, we've not really got into explaining to people, you know, that the fentanyl is low in this area. We're still hearing fentanyl's in everything. So why am I testing? That. But I do agree with you that we need to be a little bit more open and honest, and let people know that we have other substances. Like I think somebody pointed out that the illicit part is constantly changing, and we need to point out that even though fentanyl is lower, and we're seeing a rise in other things like the xylazine and the metazide, the one I can't say. We're seeing a rise of that in Perry County, and we need to make that more aware than having everybody still fearing fentanyl, and letting them know fentanyl's down, but this stuff is up, because they're going to constantly change, to fit whatever they can slide in. If everybody's testing fentanyl and rejecting the drugs, then they're going to bring something else in that's not being tested to get it in, and that's what they're doing at this point. And we need to get that out.
Thank you all. Thank you all so much. I could talk to you all day about this, but we also have another wonderful, amazing speaker, and I don't want to cut into her time, but as everyone who knows me, I could talk about all of these topics all day long, but instead I will be quiet and thank our panelists. Thank you so much for coming. This was a wonderful discussion, and we are now going to transition to our next speaker.
Thanks, Amanda and Lana and Casey, Dr. Young, and the Harm Reduction Hub for your important work and that important update. Thank you. So yes, now I'll introduce Dr. Emily Hennessy, who is presenting on recovery support models for adolescents. She is Associate Director and Director of Biostatistics at the Recovery Research Institute, Associate Director of the National Center on Youth Prevention, Treatment, and Recovery, and Assistant Professor of Psychiatry at Harvard Medical School. Her research examines addiction treatment and recovery capital among adolescents and emerging adults. She has received multiple funded awards, was named the 2022 Researcher of the Year, founded the Substance Use Treatment and Recovery Campbell Collaboration Review Group, and co-edited the Handbook of Recovery Capital. We're so lucky to have Dr. Hennessy with us today. I will turn it over to you.
Great. Thank you so much just for the invitation. And, I'm honestly a little disappointed to have to go to my portion, because I was really enjoying listening to the discussion. And yeah, there's, I think, so much to dive into there. So sorry about that. And hopefully, the folks that are still here will learn something new, and we can engage in a little different way with my talk. So I primarily focus on adolescents and young adults, and then also really think through how we can build recovery capital for kind of everybody going through a recovery journey. And so for those of you that might not work with young people, hopefully there'll still be a few things to take away from that as well. So I will talk very briefly about adolescent development and substance use, and then dive further into treatment and recovery, and then really spend a lot of time talking more about some of these key kind of frameworks for understanding what happens for a young person as they're going through a recovery process and getting engaged, hopefully with some sorts of supports, and what we can do kind of as community members, and different organizations to really begin to build out a recovery-oriented system of care to kind of really meet adolescents where they're at in their substance use and recovery journey. And I was saying, I think before everyone joined, I have a lot of slides, a lot of content. I am happy to pause and talk with folks and take questions and kind of not have to get through all the slides if we're having good discussions partway through. So don't be shy about the chat. And I'm actually realizing now, there it is. Okay. So I will be on the lookout for stuff in the chat as well. So feel free to kind of ask questions as you're curious. And if I miss something, hopefully I will get to it as we're walking through. So very quickly, just to kind of set the stage, adolescence and kind of young adulthood is a time of a lot of changes going on for young people. And we all know this because we are all adults at least. And so that was the time, if you can think back to what was going on, lots of things going on biologically and physically, as well as things that you don't realize in terms of your brain development and the kinds of thinking that you're able to do during that time period. So there's a lot of great developmental things happening, but it's all happening at once. And during this time period in particular, there's a real vulnerability to experimenting with substances. And because of that experimentation, also biologically and physiologically, to end up kind of habitually using those substances depending on the context. And as we know, during this developmental stage, because there's a lot of changes going on, use of substances can have, some really harmful effects for young people. What we also know, kind of thinking through what's happening to adolescent brains cognitively, they're still developing the way to self-regulate, as well as to kind of think ahead to the future. And so they're really more highly likely than adults to engage in impulsive behaviors. They're really looking to their friends and peer networks for approval. And at this age, developmental stage, friends and peer networks are oftentimes kind of approving more of a risk-taking kind of behavior. So we know this from animal models, and we've also seen this in studies with people as well. And then if we think about kind of the larger substance use culture in America, ads for all sorts of substances are all over the place. It's kind of this oftentimes viewed as this developmental rite of passage, right? When you turn 21, you're able to drink. Now, weed has been made legal in many states or has been decriminalized. There's this sense that when you go to college, this idea of working hard and partying hard, and different colleges are rated on their kind of partying, partyability, I guess. And so the messaging that's happening for young people is that a lot of substance use is normal and it's what you do and you'll grow out of it eventually, probably. And typically it's pretty okay. And it's kind of glamorized in a way as well. And so all this is happening. They're getting this messaging at a time when they're also really vulnerable to engage in these, risk-taking behaviors as well. And so one of the things I want to talk about too, just very briefly, is a reminder for folks that, I'm talking about adolescent and young adulthood as kind of this one stage, but there's actually different stages within this stage. So different things are going on developmentally. And initiating drug use at different points during these stages can delay some of those pieces of development. And so even though I'm kind of talking more broadly about this age range, when you're working with young people, it's really important to think through, what stage are they supposed to be in based on their age? And then how might that have been potentially interrupted if they've really initiated that heavy substance use? Because lots of different things are going on depending on where they are in that process. And, for some young adults that started substance use really late or really early in life, rather, they may appear to be, young adult kind of ready to move into the world on their own and in their recovery, but they may actually kind of still be developmentally in some of this kind of middle adolescent in terms of developing some emotional pieces that are necessary for healthy adulthood and thriving. And so I'm going to minimize everybody's heads. Sorry about that. All right, now I can see a little better. So I'm going to talk now a little bit about adolescent treatment and recovery. And when I'm talking about recovery, I'm really talking about this overall process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. This is the SAMHSA definition, and it's one I think is really important for young people because this really puts the focus on positive developmental changes and taking ownership of your life. And it totally ignores the what people oftentimes think about when you're talking about recovery, which is the substance use piece, which is important. But here the emphasis is on all these kind of positive developmental outcomes that we want to see young people achieve. And another thing that's worth talking about is just, when I'm talking about adolescent recovery, it's going to look quite a bit different than adult recovery, at least in terms of kind of their substance use profile. So young people tend to use kind of multiple substances, and they actually will oftentimes use a broader array of substances. Again, going back to that piece where they're kind of in this developmental phase of experimentation, trying out new things, and depending on where they live and their peer group and what school they go to, they could be offered a variety of substances at one school versus another school. Whereas adults, we see these different patterns of substance use that emerge. And so, sorry, I'm gonna go back and I'm gonna look in the chat quickly. Okay. Awesome. And we will be talking later about some programs for young people as well. So thank you, Michael, for sharing some of those things that you're doing at your after school program. And so the other thing about adolescent recovery is because of where they are in life, they're pretty resilient in addition to kind of being in this crazy developmental phase. And so they can oftentimes experience a lot of serious problems and consequences, but they might not actually meet diagnostic criteria for a substance use disorder, which can make it harder kind of to be identified because they're very good also at kind of hiding some of these behaviors because they don't want to be caught. And then it also, when they are identified, it can be harder to kind of get them treatment placement as well. The other thing that we know from a lot of qualitative and even some quantitative research is that they're more likely than adults to return to using substances because of their social environment, because of social pressures around them. Again, given that they're looking to their peers and their friends for approval to belong, essentially. And so within this kind of larger context, what we also know is that there is a huge gap between the number of people who need treatment, who need some sort of evidence-based treatment, and the number of young people who actually end up getting that treatment. So out of 2.2 million young people with a substance use disorder in 2022, only about 68,000 of them, under 68,000, were actually admitted to any type of substance use disorder treatment. And that's national data, thinking about kind of the publicly available data set. So this number is actually, there's probably actually more young people with substance use disorder and also more young people who may have received treatment, but it could have been privately insured. And there's lots of challenges to engaging young people. For starters, oftentimes as parents and other kind of adult officials in their life that tell them they need treatment. They may not think their substance use is a problem, in part because they haven't experienced severe enough consequences, or they're using a substance that everybody else around them is using, and so they don't understand why their use of it is a big deal. If they're using substances to cope with untreated trauma, pain, or mental health symptoms, or if they're, for example, having a hard time sleeping and they use substances to help cope with their sleep, so that the substances are serving a purpose. They're using substances for a reason. And so oftentimes, historically, the treatment system has kind of approached young people and said, substance use is bad. Like earlier, we heard about the Just Say No campaign. But we don't actually figure out, why young people in our lives are using substances. And that's where we really need to start, understand what purpose that substance use is serving, and then try to reach them from that angle. And again, I mentioned, they're seeing substance use used by their friends, peers, and parents, and they tend to bond with others through using substances as well. So I am going to pause here and ask everybody, and I will open up the chat. What are some other challenges you have run into in your community in terms of engaging young people?
While we're waiting for others to put things in the chat, someone said previously the biggest challenge they face is transportation.
Yep. Yeah. Transportation is a huge one. And it's one that I've seen, even in programs that are running, it's like, okay, well, we have this program and we know young people want to come and they try to come. And what do we do? And some organizations are able to work with like Lyft or Uber to kind of circumvent those challenges. But then there's been instances where the Lyft or Uber doesn't want to be responsible for the young person. And so there's all sorts of kind of logistical challenges as well. Yep, transportation, lack of treatment centers. Yeah, in Massachusetts, where I am, we saw the closure of one of the, I think, last adolescent specific treatment centers after the pandemic. So, yep, the challenge with the courts, the criminal legal system, which is pretty major. And what we see oftentimes is young people with access to finances and in certain kind of white middle class communities end up in treatment, whereas other young people that don't have those privileges end up in the justice system. Lack of clinicians, for sure. Lack of assistance with teens. Yeah. Certainly the perception of invincibility. And that's where I think that's where sometimes when we think about approaching this from a different lens, from a social model of recovery, You can kind of avoid the perception of invincibility, kind of get young people excited about something else and not even thinking about the substance. And then you kind of don't have to worry about the invincibility piece, but that's definitely a challenge. Yes, exactly. So Dave said, from my experience of working with young adults, especially in sparsely populated geographies, who will make up my new non-using social world? Yeah, so that's a huge challenge, especially, we think about for folks like adults, you could move, you could get a new job, but young people are often tied to their neighborhoods unless they have another family member they could live with, which we hear about happens sometimes as well. Parents are locked up. Yep, definitely. So we know, family substance use, parent substance use, and trauma associated with that is a huge risk factor for young people. Yeah, so stigma. Yeah, so this is interesting. So stigma and really being appealing to young people, I think. So there are some resources, but young people think they're not cool or cultish or not attractive or fun for them. And we've seen some really nice work that with some groups that I'll talk about kind of a little farther in, that have done a great job of kind of flipping that and making it really attractive for them. So I'm going to go on to the next set of slides. Yeah, funding, of course. That's kind of, and in the current funding climate, we're seeing even more challenges with that as well. So those are all the challenges. And I think we kind of covered most of those with just at what everyone put in the chat. And the numbers around these pieces too, just in terms of treatment access and availability, this more recent study found that less than 17% of adolescents who needed treatment actually got it. What we've seen as well is that males are more likely to get into treatment kind of earlier than young females, and white youth are more likely to get access to treatment as well, compared to kind of Black or African American young people. What we also see is for young people with any sort of comorbid mental health condition, so depression, anxiety, those young people kind of have a longer recovery process trajectory, and that can be really challenging, especially if just the substance use is attempted to be addressed, but not the underlying mental health issues. And we already touched on the criminal justice system piece as well. So now I'm going to try to kind of flip our discussion a little bit, and rather than talk about barriers, really think through some opportunities through two theories that I like to use in my work. And I'm also going to be talking about stigma and what that looks like for young people in a recovery journey. So what do you think when you hear the now buzzword recovery capital? So it's a buzzword in my space. It might not be in yours, and that's fine, but I just wanted to see if anyone had any thoughts about recovery capital before I talk through that theory. Oh, Callie, I saw you type something, but I don't quite, I might have missed the end of what you meant to put in the chat there.
Maybe it's all the talk. It's all the talk.
Oh, all the time. Okay. And I was gonna say maybe it's not a buzzword in your space as well. So maybe it's good that I have it here. Yeah, exactly. Tools you have to use on your recovery journey. Sure. Yeah. Yeah, the foundation, right? It's like it's a primary tool. Oh, okay. So you're measuring recovery capital, Matthew, it sounds like, or you're using it to kind of think through how you work with folks. Amazing to see investments in others and how it grows our local communities. Yeah, and Mark, that's a really wonderful point. Because what I like to remind folks is like, it's not recovery capital is not just about helping the individual, but it's actually about building out the community, because when you begin to build resources for recovery capital, you really see those effects across the community and not just for that one person. Thanks, Kelly. That's okay. Recovery capital's resources people have for their recovery. Yeah, thanks, Heather. Okay, Alex. I think people often think recovery capital refers to these supplementary resources that are useful after treatment or something like that. How do you, in your brief elevator pitch on recovery capital, explain that it is primary and not secondary? That's a great question. So because I work with young people and because I think the picture that we see with them is that they're kind of in and out of treatment and in and out of a recovery journey, I tend to really package it as like recovery capital is this way of thinking about resources that can kind of prevent someone from using substances in the first place, but also support their initiation of treatment or other sorts of recovery processes and the maintenance of that. And I think this brings me nicely into my next slide. So as everybody mentioned, recovery capital, total resources to overcome substance dependency. Robert Brainfield and William Cloud wrote the initial book that made this term a reality. So coming clean, overcoming addiction without treatment. I realize that's really stigmatizing title of a book, but this was in the 90s. So there it is. But I think what's important to kind of lay out here is that, this was in the 90s when this book came out. They had done a study of kind of middle-aged white males who had recovered or identified as having recovered without any sort of formal treatment. So this is a group of men who said, yep, I had an alcohol use disorder and I no longer do. And I never did treatment or any sort of self-help groups, I think. And in analyzing those interviews and going through those interviews, and actually, I think through several barbecues, because these two men had a relationship outside of their kind of research, they were friends, they talked things over. They really decided, these men had resources that enabled them to recover without any sort of external resources, and we're going to coin this recovery capital. And what they said was they had jobs to return to, they had families they didn't want to leave or lose. They had all these things in place already that at some point they realized they were going to lose all of it, and it was enough to make them not want to lose all of that. So they made these changes. And so what's really important is it's obviously a very select group of privileged folks that were studied for that study, but the idea kind of stuck. And since that time, we've had a lot of research and kind of theory and people thinking about recovery capital to get to this point where it's like, it's not just relevant for those folks. They had what we term high recovery capital because they had these kind of internal resources. They had these external resources around them. They had a lot of recovery capital, but there's a lot of other people who also have recovery capital. It just may look like quite a bit differently. And so in my work with young people, this is a model that I use. And one of the reasons I use it is because it has these 4 domains that I'll talk about in a minute. But it really kind of flips this picture of substance use disorder and addiction on its head, because it says, let's think about the resources, youth resilience, unique developmental aspects within their broader context. Like, think about all the resources that they have themselves and through relationships with others and where they live. And let's use that to build an understanding of how they can not only initiate substances in the first place, but begin to recover once they have initiated that substance use. And so what I love about this model, in addition to being strengths-based, is that it really situates a person within a larger context. It says, it's not just you that's the problem, right? It's all these other things that are around you and within your larger community. And all those things have to be healed so that you can begin to kind of generate more recovery capital. And there is the idea that recovery capital changes over time as you're going through a recovery journey. You may have ups and downs. Individuals with some resources are likely to kind of generate more just because of the synergy of having these resources in place. And so there's kind of these 3 levels. So I'll talk about the individual level first, and that's really kind of situated with the person. And I'll talk about, there's folks use all kinds of words for the different domains, but I'm going to talk about human recovery capital and financial or physical recovery capital first. And so for young people, human recovery capital is really this idea of having self-confidence or motivation, having all these internal resources to kind of begin to set and meet some developmental goals. And really it's the characteristics that they were born with or have developed up until that point. Okay. Financial recovery capital brings it out kind of to, it's still within that young person, but you have to really think about it because they're part of a family. what sorts of resources their caregivers or other family members that they're living with have. So whether their caregivers have enough income to kind of provide a stable living environment, health insurance, transportation, which we've already talked about, treatment access, so like tangible things that can help support a young person's recovery are what make up financial recovery capital. So the next piece, though, because it's not just about what that individual has themselves, but it's really about what's going on around them. So that's this individual level, social recovery capital. And that's really where a lot of, I think, the work around building out community resources for young people comes out. You build out the community recovery capital resources in order to generate new social recovery capital for young people, in order to help them identify and connect with new social groups that will support their recovery. So social recovery capital can look like, sober and supportive friends, or friends that are at least supportive of their recovery. And that kind of support can look a lot of different ways. And I've talked to a lot of young people who have kind of outlined different ways that different groups of friends support their recovery or get in the way of it. It's also having supportive and a really structured family environment so that they kind of have these expectations for their recovery process and feel supported by those different family members that are a part of that. Having a sober home environment for a young person engaging in a recovery process is really, really important. Oftentimes in talking to youth where their parents are still using substances and haven't made any changes, even if it's like still drinking alcohol because it's culturally what they would do at dinner, it kind of reminds the young person that they're not like their family and they can't engage in that use, and can be kind of stigmatizing for them, and feeling like, my family views this as my problem, but I'm having a hard time in this environment. We see that a lot with young people. And then the other piece about social recovery capital is just having these developmentally appropriate groups where young people can begin to find other people to connect with. To the earlier point, what are some groups that are doing fun things that I want to do, that are attractive to me, that make me feel accepted and cool. But there's no substance use that are part of those. And I'll talk a little bit about those as we get into the later portion of the talk. And then finally, the community level or community recovery capital. In the United States today, we have a lot of, but not enough, recovery high schools. And so those are high schools for young people that are in the process of a recovery journey. And some of them are actually called recovery high schools, and some of them are just called sober schools. And some of them are just, you don't know that it's recovery high school until you go to the website because it's not in the title, but they still emphasize this approach of kind of a sober school environment and recovery and academics. And really the idea behind community recovery capital is, are there these broader community level supports available to young people? And what you can see from this map is, there really aren't, if we think about the population of young people across the United States. And the other piece about community recovery capital is, is being in recovery a valued identity in your community, or is it stigmatized? And what are the larger kind of perceptions of substance use and recovery in communities? And so I think before I I had a few questions, but I might save those. Before I go on to thinking through stigma a little bit and talking about what that means for young people, I did want to know, has anyone run into some of these community recovery capital resources or heard of them before? Oh yeah, bullying. Yeah. So if we think about bullying and relation, especially if it's around being in recovery, or and we think about social media and bullying as well, that those are real big challenges for young people. No recovery high school in Kentucky. Yeah. Yep. And so there is, I'll put this in the chat, the Association of Recovery High Schools, should be ars.org, I think. I think they should have a live map where you can look and see where the closest one would be. But obviously, if they're not in your state or in your district, it can be really hard to attend those. Okay, and so the piece that I wanted to talk about, oh great, you had the ARS folks present. Perfect, that's awesome. So you all already know about Recovery High Schools. The piece that I wanted to talk about in terms of stigma is, I think it's something that's on everyone's minds, and it's really important and really challenging, especially when we think about how important belonging is to young people as they're kind of figuring out who they are in the social world, and if they're going through a recovery process. So the basic definition of stigma, just so we're all on the same page, is an individual or group is considered to have a devalued trait that can lead to being negatively judged, left out. And it also has been shown to lead to other negative consequences. So it's been linked to folks, avoiding disclosure that they're using substances or kind of in the process of recovery, to the point where they won't engage in treatment as well. So they won't want to out themselves if they're going to treatment because they don't want other folks to know. And it's also not just something that happens to you, but it's kind of enacted in or comes out in a variety of ways. And so the first form of stigma is just perceived stigma. So you kind of worry that you're going to be stigmatized because you hear about how people talk about people who use drugs in a negative way. And so you think like, oh, I need to be careful about what I say or what I disclose because I think I'm going to feel like someone's going to stigmatize me. There's also an active stigma, and that's usually when there's some sort of active stigmatizing event against a person. And so it's very clear that they, like their doctor won't give them any sort of pain prescription because they knew that they were addicted in the past. To even to alcohol, but they would use that kind of as a way to stigmatize their clinical experience. And then there's this also the idea of internalized stigma, which is essentially where you self stigmatize, right? So you perceive the stigma around you, around what it means to be someone with a substance use disorder or in recovery, and you actually begin to take that on as part of your identity. And so all three are challenging and disruptive to health and well-being. And I was just going to look here, monthly champions meeting for local business. Oh, great. Okay. Yeah, so I was just trying to stay attuned with the chat, and I'll come back to some of those when we're done. We did some recent, or kind of later on, we did some recent work talking with young people about their experience. So these were all young people that had gone through some sort of treatment and or recovery experience. So they had actually gone to formal treatment or they were part of a recovery high school. And we had them complete these maps of their social networks, which I don't have time to get into today, but it's really interesting and fun to talk about. But as part of that, we asked them questions about the people in their lives and who knew about their experience with recovery and who didn't. And what we found was essentially, these three conditions. So a young person chooses who to tell. A young person experiences unintentional disclosure. So they went away to treatment and their friends found out and told everybody, or, their parent notified the school who teachers, told other people. And so they weren't in control of their disclosure of their experience. And then what we also found was this third group of young people who had the option, right? So they could choose who to tell and who not to tell. And they were pretty clear about why that was the case, which I'll get to in a second. We also asked about, their preferred terminology, right? Like, how do you want to talk about your experience? And it was a real mix of things. So some folks said, yeah, I really, I like to talk about myself as in recovery or someone with an addiction. Some young people actually said, I don't really care. It doesn't really matter to me. Some young people also disliked kind of what we think about as a traditionally stigmatizing terminology like addict or alcoholic. But then they would also refer to themselves in that way. And so when we dug into that a little bit more, it was really interesting. So essentially it was, if I'm having a conversation with someone and I can own that identity, this is how I'm going to talk about it. But if they're talking about me, then nobody should be using those words, right? And so it's really important that when we're sitting down with young people and talking with them about their experience, to kind of see, how they want to be talked about. or with, how they want their condition to be referred to. And so what we also found was, they really tended to be more likely to tell close friends or recovery groups and some trusted extended family. Oftentimes their immediate family was aware of what was going on, and sometimes adult staff in some programs were also aware. But what we also found was for some older young people, they would say, well, I'm working and my work group doesn't really need to know about this, or I'm going to be going to college next year and nobody needs to know about my experience. I've kind of put that behind me. And so what we see is that for young people, they may actually kind of decide for themselves, if they've moved to a new space, once they have that freedom to do so, that they don't want to share this with anyone. That's kind of how they're going to approach that. And so lastly, because I did start out by talking about disclosure, there was a mix of experiences after this disclosure. So for some young people, they felt supported, but not watched over. And so in those cases, it was really helpful. But in other cases where they felt kind of watched over, it was like, well, now you just make me feel different. And I don't like that, even though you're trying to be helpful. So it was this tension for them. Some young people definitely expressed interactions with others where they felt really stigmatized. But what we saw overall was that for those young people, they had this awareness of what other groups kind of how they could be stigmatizing, and that they just weren't going to care. They were essentially just very resilient. They said, I figured it out. I'm okay with myself. I don't care how they talk about me. And so, we do see this great mix of responses, which is really important, I think, when we are working with young people and figuring out, how they want to disclose, how to work with them in order to be able to disclose, or how to have those conversations, especially if they have to return to school after being in treatment. Like, how do you tell your friends about where you were? Like, let's practice some of those conversations so that you feel really comfortable. And kind of, if there's ways that programs can be doing some of that and transition planning, young people may be better set up when they kind of return to their communities after these treatment experiences. So I'm looking at the clock, and I'm definitely only partway through the material, but I did say I had a lot to share. So one of the last things I wanted to talk about, and it really relates to how we think about social recovery capital work. So I talked about social recovery capital as, those kind of recovery supportive relationships in your life. And there's another theory that actually fits really nicely in that it's called G-Chime. It was actually borrowed from the mental health literature. But it's kind of more recently been proposed in the addiction space to really provide a way to think about how social recovery capital operates. And so the underlying idea is that there's this initial connection needs to happen. This is kind of like the gas, if you will, that fuels a car. Connection is the gas that can fuel a recovery journey. And so without that new infusion of support and belonging, it can be really hard for a lot of folks, especially young people, to have this initial kind of hope. But if this is successful and they feel connected in a new way, hope should initiate, which ultimately leads to this cycle of developing meaning and purpose in life, feeling empowered, and developing kind of this new identity, right? An identity that's supportive of their recovery. And throughout this process, what we need to have is kind of this growth, or what young people need to have is this growth mindset. So the ability to adapt and change behaviors and responses so that you can be flexible in these new situations. And I'll talk a little bit about why this is important when I get to some of the recovery support models that I wanted to throw out later. So I'm going to go quicker through these slides and then get to the actual programs that I wanted to talk about a little bit. But the idea behind a recovery-oriented system of care is essentially that there should be no wrong door to enter treatment. So for young people, we should have lots of opportunities in the community to get them plugged into the level and type of treatment that they need to address their substance use and anything else that goes along with that, including the mental health challenges that they may be experiencing. And the other idea with it being recovery-oriented is there's no right path to recovery. So lots of different recovery paths are welcomed and accepted, and we should have programming opportunities for everybody interested in different ways of approaching their recovery. And so the other piece of this that kind of shifts the relationship between How we used to think about treatment and recovery to how we should be thinking about it now is that it's not like just one period of like you go to treatment and you go away and you're fixed and you come back and everything's great. But really for young people, and this has been demonstrated for adults as well, it's this idea that you may need several different types of instances of treatment or recovery support to kind of initiate that recovery journey and then sustain it over time. And during that time, you may see returns to use and we may see risk behavior increasing. And that could come about because of changes going on in the environment. It could come about because of stressors that are happening or cravings, or there's lots of different reasons that happens. But a recovery-oriented system of care would operate from this philosophy that, well, if that's the case, we need to figure out what support they need now and get them hooked into it. And so for young people, it's really important that we think about that and kind of have a variety of options for young people in their communities, including making sure that families are welcomed and a part of that entire process. So what I did want to spend the last bit of time focused on is this idea of what an adolescent recovery-oriented system of care is by giving some examples of some of these positive programs. And I'm just double checking. Oh, great. Thanks, Amanda. Okay. So ultimately, when we're talking about a recovery-oriented system of care, and I'm talking about it specific to young people, the ultimate outcome is positive youth development. What we want is for young people to meet the challenges of adolescence and adulthood through this set of activities and experiences, which essentially help them to develop in all the ways that they need to develop to become kind of successful adults, however we want to define that success, because I know that can be a loaded term. And when this group at SAMHSA examined and discussed, what are some outcomes that we should really focus on if we're going to build out a recovery-oriented system of care for young people. They had these three categories. For youth, it should be ensuring that they're socially connected. They should be able to give back to the community. They should, as they're developing, they should have this self-sufficiency that's appropriate for them developmentally. And they should really have been building out these different aspects of positive youth development that we would expect to see by the time they reach young adulthood. For families, we should see this sense of family health and well-being and recovery, and the ability of the adults in the family to be supportive of that young person in their life. And then the larger system should have lots of supports, not only for that young person, but also for family and sibling recovery. And again, easy access to the service system for families through multiple entry points. Which I think is going to take a long time to develop. And some communities may be really good at this, especially communities that are starting to build out inclusive recovery cities. But from what I know about the system and what you all, I'm sure, have experienced, is there is typically not easy access to the service system, and you oftentimes need advocates to help you navigate it, especially families who might be new to this process. And so these are the outcomes that they emphasize, this group, in a recovery-oriented system of care. What is missing from this list of outcomes? Does anybody want to throw a guess in the chat? Sobriety. Yep. Abstinence. Yes. Yeah, exactly. So this group of experts at SAMHSA came together and they said, these are all the outcomes we want to focus on in a recovery-oriented system of care, right? And so that's where I really want to think about the emphasis for these different programs that I'm going to talk about. That's where these programs have landed. They think about how to address substance use in a really thoughtful way, and how to make the focus on engaging young people meaningfully and ensuring their positive development. Yeah. So I'm going to talk about kind of these four systems today. Hopefully, if I have enough time, really focusing kind of more on some of them than others, because there's more research and more good examples from some of them versus others, because this field, even though we've had adult treatment and recovery research for a very long time, it's typically kind of neglected young people. Oftentimes I think historically it was, this worked for adults, so it should work for teenagers, but, teens are not mini adults. They're very different developmentally, as we've talked about. So I did want to talk a little bit about the community system and some examples of, these positive supports for young people, kind of in recovery or even not in recovery, right? To just begin to develop out meaningfully and be engaged, or would be alternative peer groups, recovery clubhouses, any sort of your kind of sports teams, arts, music, drama, churches, and other kind of faith or religious organizations. Opportunities for job skills and life skills training, and then support groups as well for parents as they're navigating how to parent a teenager. And so when I talk to young people about what they view as recovery capital resources, we had some really nice quotes that I did want to share. So one young person said, stimulation outside of the program and like having something to go back to where you're going to be able to be stimulated and not be in an environment where you need to use drugs. Someone else's, I think boredom is a big one, or having an event in your life that's extremely hard to go through. And so both of those instances, they kind of highlight different things, but kind of the underlying idea is, an opportunity to engage in something meaningful that means something, and that they can kind of get passionate about. And I remember working with one group that had a huge drug problem in their community, especially among their young people. And what they recognized kind of early on with the problem is that young people in the community didn't feel respected. They didn't feel like they were part of the community. It was more of a tourist destination. And so the town council had actually removed the benches in the park because the kids were kind of congregating there and they felt like it wasn't a good look for their town. And so this really made the young people feel devalued. And so this group decided, rather than just focus on the drug problem and like just say no to drugs and figure out what to do there, they said, we're going to bring young people in and have them be part of our community in a way where they have some voice, they have some power, and we're going to ask them what they want to focus on so that they begin to feel like they're part of the community life and valued. And that made a huge difference for them and for their young people. And I think the last piece of kind of comments that I wanted to share was just around for young people, especially, this idea that their friends are starting to experiment with substances is kind of like a natural part of development. But for young people that have identified early on that they have a problem and realizing they have to be sober and kind of separate from their friends, it can be really hard then to find other young people. Like, who do I hang out with? Who do I connect with? When I was using substances, I felt more comfortable around others socially. Like, now what do I do? How do I find these new friends? So alternative peer groups are a really nice example. The idea is exactly as it sounds, to establish new social networks. There is an association of alternative peer groups and they have a website. And the whole idea is really around valuing and modeling recovery, with the idea that it should be kind of a fun recovery experience for young people. So they're doing fun social events, things that the young people want to do. And that is kind of what tends to bring the young people in. Then they have this wraparound of programming. So they have community recovery meetings for young people. They do individual counseling for young people, especially to kind of target some more individual level needs. There's also huge family support and parent programming components that includes, some of them include family groups so that families can learn from other families who have gone through something similar. There is a psychosocial education piece, and then case management kind of wraps everything together. And so when we looked actually at the alternative peer group model through that earlier GCHI model that I was talking about, we actually found it really kind of nicely highlighted what was going on in the alternative peer group. So we examined interviews with young people that were they were kind of looking back on their experience in the alternative peer group. And what came out the most was just this idea of connectedness. So a lot of them did not want to go to the alternative peer group initially. It wasn't something they were excited about. It wasn't something that they identified on their own typically. But they were oftentimes kind of brought there by a parent or another adult. And because they were doing so many fun things with others in a sober space, they just started to make these new connections naturally in these groups. And that was what got them excited to go eventually. So as they figured out, I'm with trusted adults who care about me. I'm with peers and we can have fun together without substances, that initial connection was really what kept them coming to the group. For some young people, so that was the case for most of the young people that were interviewed. For some young people, it was more about their internal motivation. It was a small subset that didn't feel connected, and they just knew, I want something different in my life, and I'm going to take the steps that I need to do. So that's why it's kind of important when we have these theoretical models to revisit them when we have data that we can kind of situate against them. And I can say, so Amanda, regarding recovery community centers across the country serving youth, RCCs typically, just given their funding and other programming structures, are like 18 plus from my experience, although I know there are some that are kind of trying to do more of that, which is why I think the alternative peer group model has taken off in some places. Okay. Okay, I didn't have more highlights there. And so essentially what we found was, in addition to connectedness and motivation, we did see this trajectory where folks moved from that initial connectedness into having hope, into seeing that there was a different future for them. And then as a result of that, beginning to identify with that recovery group and with those ideas around, I can be a person in recovery. It is attractive to me. I can find meaning in life through the changes that I've made. And downstream kind of having this feeling or experience of empowerment. And so I will take a second, for those of you who work in youth serving organizations, I'd just be curious to hear if anyone has seen this kind of happen in their young people in this order, or maybe experienced something different. I would just love to see if anybody had any thoughts around that before I move on. And I think Mark has said sapling centers, the hub model. So is that one, Mark, that would serve young people and not just adults? The sapling centers, KRCC? Okay, awesome. Great. Both of those in the chat serve young people as well. And I'm just going back through. So Callie had said schools in Eastern Kentucky have implemented Climb 2.0, and there's a Phoenix school in Louisville, but the options are really limited. Yeah, and so a lot of that, I think, comes back to funding and accessibility as well. A lot of these programs can be quite expensive to run, and most of them, and I'll get to recovery high schools in a few minutes, but you all would have talked to the folks earlier in the fall. A lot of them try to be free for students, and so that can be really challenging from a programming perspective. All right, I will move on if nobody had kind of experiences they wanted to share there. Dave said, big question for me with RASC. How do we leverage the growing popularity of the recovery capital model to demand more and more equitable resource availability for young people? Yeah, I mean, I think it's like the key challenge. What I've started to think about, and David Best and Johanna Ivers have written on this as well, is just this idea that when we begin to really invest in our community in ways that are recovery supportive, like inclusive recovery cities, or having a collegiate recovery program on a college campus or a recovery high school in a community, it gives back to the community beyond just to those individual students that are there, and really can grow out a really positive, lots of positive results for young people that kind of give back beyond the initial investment. But I think it's just really challenging to do, and to, some communities get very excited about it and are on board right away, and then others, there's still that stigma. I'm running a research study now, and we're trying to just support young people with free treatment, and we're talking to schools, and they're saying, oh, we don't have substance use in our schools. Like none of the kids that attend our school are using drugs or alcohol or anything. So there's still, that huge kind of stigma at the school or program level around, we don't want we don't want to be perceived as the school where everybody goes to use drugs, even though it's just very present because part of that community life oftentimes. And Kelly said there's one in Paris called the Voyage Movement. That's really interesting. That sounds like, I guess, the RCC. I'll have to look that up. Okay, I'm also going to talk a little bit. So evidence for APGs, I always like to give a little evidence. We don't have much about alternative peer groups. Angela Nash has done the most extensive work on this and essentially really highlights how they can provide developmentally appropriate services and that they're viewed as valuable by youth and their families and even their communities and can support a process of change. But it's been really hard to get that research funded beyond those initial studies. And so we need to do more work there. I did want to briefly just mention recovery clubhouses. If you scan this QR code here, you'll be directed to an open access paper that talks about what the recovery clubhouse model is. So what's cool about this is it works with young people 13 to 17 years and their family. It's year round, it's no cost for the young people. And it's, the offers that they offer are pretty extensive. So it covers all that, out of potentially a lot of that out of school time where a lot of trouble can happen for young people. They have 8 sites across rural and urban Georgia, and they serve a lot of youth annually and provide a ton of services. And I think in particular, with this population, they've recognized that the young people don't have access to a lot of resources, kind of maybe some low family financial resources. And so they'll do just fun things and pay for them. So they'll take all the kids to the movie and provide the transportation, which gets them out and about and doing something in a safe environment. And so I think it's a great program model. They have kind of several different sources of funding actually, and ways that they've integrated this into their system across Georgia. So it's worth thinking about at the community level. All right, so we talked a little bit about that. We did talk about the recovery high schools already. So I don't want to spend too much time there. But I think it's important, beyond just the recovery specific high schools and collegiate recovery programs, thinking through what are opportunities in our education system to bring out a recovery oriented system of care, to identify students early on, to support them when they return to school. And so this, one of the young people I talked to was really highlighting this. One of their teachers in their regular school that they'd gone back to, not a recovery high school, knew about their treatment and their sober dates and would congratulate them and say, and really just recognize that for that student and make them feel belonging. And if we can do a better job of educating our educators around this issue and providing some structure and support in our schools, and that those early identification pieces, we could be going a long way to better support students in our public school system, especially. So I'm not going to spend time on recovery high schools, but the idea is they offer that kind of recovery support and acknowledgement of young people there are working through recovery experience, but they're also building out family relationships and support and ensuring that they can kind of meet their developmental goal of graduating. Collegiate recovery programs are programs on colleges or university campuses, really to provide a safe space for young people in recovery and offer a variety of services. And their website is below if you want to check it out. Just check the chat here. Okay, that's a good point, April. Hopefully we can come back to that before we end here. All right. And so briefly, the evidence on recovery capital and recovery outcomes for young people in recovery high schools and college students is positive and suggesting, these resources actually do have cost savings down the road if we invest in them, but we need to do that in the first place. Talked about that. The last thing I just wanted to mention briefly, we had touched on the justice system. There are juvenile drug treatment courts in the US, and I have been working on the past few years with a subset of them to implement this recovery-oriented system of care model, to think about how to measure and use recovery capital in their planning. And so it's like very new work. I don't have data to present, But essentially, we're seeing throughout the US, I think because of like the buzzword that recovery capital has come, this idea that, we can really start to shift some of these traditionally punitive systems in a way that will have benefits not only for the young people that are part of them, but for our communities and for the staff who work with those young people. And so I would say be on the lookout for some more things happening in some of the juvenile drug treatment courts that are doing some innovative work in that space. So in summary, kind of big picture, when I think about an adolescent recovery-oriented system of care, the idea is to begin to build out all these different domains of recovery capital. And that really, from my perspective, given what we know and what we've seen happen, it's investing in our communities to build out programs and resources for young people to begin to create new social capital. When we do those two things well, we begin to see changes in their human capital. They begin to get motivated. They begin to get excited to find that meaning and purpose through those social connections as a result of having those community resources, which ultimately I think is more of a downstream effect when we're talking about financial capital. We're thinking longer term, if they've gone on to college or a trade or something down the road. But so these are the kind of big picture ways that we think about how the system could work to build out these domains to ultimately see kind of these better outcomes for young people. And like I mentioned before, what we expect to see are these trickle up effects of building recovery capital. David Best and Johanna Ivers talk about this as like the sprinkles on top of the ice cream cone. When you begin to build out these resources for the individual, it really begins to affect the family, the larger network, and the broader community in ways that we had not maybe even anticipated, but there's a synergistic effect that can happen. So really important for investment. I did want to mention, because I've talked a lot about recovery capital, David Best and I just co-edited the Handbook of Recovery Capital, and we talk a lot about recovery capital, lots of different chapters written by a group of international authors. It's kind of different views on recovery capital and what it could mean for program planning communities. And there is a 20% discount code if you're interested in that, but no pressure. I just wanted to share that since we are all on the call today, and it's nice to get something on sale. So I think with that, I'm going to look and see if there's more in the chat, and I'll give folks a chance to scan the QR code if they wanted. And I'm going to go back to some of the questions that I might have missed early on. So Alex, I think this is an early question that I missed. If I'm familiar with organized abandonment, let's say I presented on recovery capital recently, and someone asked a really compelling question connecting organized abandonment to recovery capital on broader ecological levels, targeted disinvestment, carceral shift, and public health, broader neglect of people who use drugs. I would love to hear your thoughts. Yeah, so I think it's a great idea. I'd have to dig more into the sociological literature to think through what organized abandonment would mean in this space. But I definitely think you're right, and we've certainly seen that in the past year, where we're having lots of changes around funding and what we're investing in being shifted from public health and well-being to other things. So I would want to definitely dig into that, but again, it gets to that larger, like what's going on in the larger community, in the larger context, even the policy context, that's really affecting our ability to have these inclusive recovery spaces. And then I see April had a comment. A lot of people and businesses benefit financially from people becoming addicted to their products to get them to consume as much as possible. I definitely agree. And I think there's been some interesting debate in some of the 0.0 alcohol product. So we see, offering non-alcoholic beers or other drinks to kind of on the one hand, support people who are trying not to drink alcohol anymore. But what we've seen is actually in a lot of the marketing, they're trying to kind of appeal to younger and younger crowds to kind of get them interested in it early on and used to the taste. So there's this kind of challenge of, how on the one hand to support folks who are genuinely, trying to reduce their use or trying to be in a recovery space and still feel like they can, have a drink the way that they want to, versus like the public harms of getting young kids or younger folks kind of acclimated to, the non-alcoholic beer put out by Guinness, right? So, and I did not even talk about today. So, other addictive things like social media, video games, these other pieces that are kind of a part of a young person's experience growing up and really affect their developmental trajectory. And I don't think we've seen enough research on the harms of social media yet. I think that wave is, we'll see that wave coming in the next 10 to 15 years. I think those are all my slides, so I can go ahead and stop sharing. And I think I'm just about out of time. So thank you all. That was a long time for me to be talking. And thank you all for putting stuff in the chat. It was really interesting to see and hear from you all. So I will, my email was on the last slide, so I'm happy to take kind of follow-up questions later on from folks, but thank you.
Thank you, Dr. Hennessy. That was awesome. I very excited for a new acronym in my life, the G chime. Might have been having some nerding out text messages with other people. So thank you so much for that. And for any peer support specialists wanting continuing education credit, that link to that survey is in the chat right now. And we'll keep the chat still up if anyone has a final question that they want to throw in there. And also thank you to Amanda and the UK Harm Reduction Hub for their update. G chime, sorry, I just saw it come through the chat, made me laugh. And one last announcement regarding this webinar. We're excited to share some upcoming updates to this webinar, which will continue to be presented in partnership between Voices of Hope and the University of Kentucky Harm Reduction Hub. Nothing about that collaboration is changing, but what is new is that Voices of Hope is now housing its trainings under an exciting new initiative called CREW, K-R-E-W, the Kentucky Recovery Education and Work Skills Collaborative. CREW will serve as the home for educational programs developed through collaboration between Voices of Hope and academic institutions. Through this initiative, we aim to intentionally blend lived experience with academic rigor to deliver high-quality, evidence-based trainings for peer supports and others who work alongside the recovery community. And as we transition some logistical elements, you can expect to receive a few notification emails as we move the webinar under the CREW umbrella. And I'm checking the chat one more time. Looks like lots of thank yous. Lots of flowers in the chat. I don't see any other questions, but thank you again for being here, Dr. Hennessy, and for everyone who joined today. We will see you on April 7th for our next episode. It's the first Tuesday of the month at 10 a.m. Eastern Time. Thanks, everyone.